Okay, so good morning. So today we're talking about stress, anxiety, obsessive compulsive disorders. You will note that I did put up your case study. So I put that up this morning. That's due on Friday, and it actually is about PTSD. Okay, so that should help reinforce this information. So first off, were there any questions? I do want to make sure that we can differentiate these disorders based on descriptions or scenarios. So are there any questions about these on the advanced organizer?
I do have a question about body dysmorphic disorder.
Mm-hmm.
Okay, so is there something with this disorder? Is there something actually wrong with the person? Like, I know it was talking about body parts and stuff like that. Or is it just in their head, like they think that something's wrong?
Primarily, it's in their head that they think that there's something wrong. Not to say that there's not something that they might want to change or that they're fixated on, but the key here is that even if they get surgical change to it they're not happy with it, or it moves to another body part. So a lot of times they think that people, when they talk about kind of being addicted to plastic surgery, or somebody like Michael Jackson, where he had his nose redone and redone and redone, that those people may actually suffer from this. Of course, we don't have any evidence that they do, but that's kind of a thought behind it.
Okay, thank you.
Welcome. Any other questions? Okay, so I'm going to pose a couple questions then to make sure we know the difference. So what's the difference in symptomology between PTSD and acute stress disorder?
Acute stress disorder resolves within a month, and post-traumatic stress disorder lasts longer than a month.
Okay, so is there really a difference in their symptoms?
Not that I thought, no.
No, there's not. So their symptomology looks very much the same. The biggest difference is the timing. Very good. How would you characterize, if you could say just in a couple words, how would we characterize generalized anxiety disorder? What do they do or have?
They're in severe distress. It's different from other anxiety disorders. They have pervasive cognitive dysfunction, impaired functioning, and poor health-related outcomes.
Yes, that's all true. There's a couple words though, just a couple words. They have excessive
Worry.
worry. There you go. Very good. Thank you. So all of those things were true though. The other one I want to make sure that we understand OCD. So what are obsessions versus compulsions?
Thoughts, impulses, or images that persist and reoccur.
So obsessions are the thoughts, yeah, absolutely. And then what are the compulsions, Maria?
Ritualistic behaviors.
Behaviors, they're actions. Okay, very good. So obsessions are thoughts, and then the compulsions are the actual behaviors or the actions that result from those thoughts. Very good. And then agoraphobia. This one, even your textbook doesn't quite, in certain parts of your textbook, it doesn't quite get the definition fully. So I want to make sure that we understand what this definition is. Does anybody want to take a stab at it?
That's a fear of like open spaces. That's hard to explain. Like just kind of like a panic of just the openness and like the embarrassment and insecurities.
Yes. So what it technically is it's a fear of being in a place in which you cannot very easily reach safety. So whether it's the middle of a field because it's open, think about being on the pitcher's mound in a ball field. You know, there's no place really to get to for cover, or it's being in a place like an airplane Can you easily escape that? An elevator, can you easily escape that and get to a place where you feel safe? So that's why it's not just open spaces, but it's any place where you might not be able to like take cover, okay? And that's why a lot of times these people end up completely isolated in their homes. Very good. Okay, so if we're talking about, so we're on the handout, talking about anxiety, stress, trauma, obsessive compulsive disorder. So these are the most common psychiatric disorder in the US, and there's a lot of comorbidities with them. It affects personal, occupational, and social functioning. So that's personal, occupational, social functioning. Depression and substance abuse are also common. And what we're really seeing here is that the person is using rigid and ineffective ways to control their anxiety. So rigid and ineffective ways to control their anxiety. So when we look at the theories behind these types of disorders, there's biology, so their genetics, traumatic life events, psychosocial factors, sociocultural factors, especially when we get to OCD and panic disorder. There's a big genetic component, as well as with PTSD and generalized anxiety disorder. Those are really high genetic components as well. Another belief would be a part of the biology is that GABA, so we know that GABA is a neurotransmitter that has to do with anxiety. So GABA is calming. GABA is calming, but it may be blocked in people with anxiety disorder. So maybe blocked in people with anxiety disorder. Learning theorists, so the theory is that the learned response can be unlearned. So things like a phobia, and I know I've mentioned this before, but somebody can learn to be afraid or have a phobia because they see other people afraid. So phobias can be learned through modeling. And we can then unlearn these responses with support. So that's kind of how the systematic desensitization would work, is that you have support and you unlearn those responses that your body goes through for a phobia. Now, an example that I give of this is, as you know, I'm afraid of spiders, and that actually kind of goes out into other insects as well. So I don't like many of them. And I used to be particularly afraid of bees. Okay, I'm not allergic to them, just don't like them. So what I was actually, my daughter was the kinder care that she went to. Actually, they raised bees. One of the teachers in there raised bees at home. So she was super calm around them. And so she would be one of them that took them out for recess. And every time there was a bee around, and the kids want to panic, because she taught all these little kids how to be calm around a bee and that nothing would happen and that nothing, bad happens. And so my daughter actually just learned how to role model to me about how to be calm around bees. And so I actually have unlearned being scared of bees because of a 3-year-old, So, so we also just have to keep in mind that we can spread those fears too. If we're fearful of something, then we can make others fearful too. So cognitive theorists look at distortions in an individual's thinking and perceiving, and that needs to be reframed, which can change functioning in the brain. So if we change how somebody thinks and perceives, they make different connections neurocircuitry changes. And so that can actually have profound, benefits to the patient. Client consideration. So the biggest thing here, I don't usually get into very specific cultural differences a lot, but just understand that some cultures may be more somatic with their anxiety and others may be more cognitive with their anxiety. So some may have more thought type symptoms and others may have more bodily symptoms where they get headaches and stomach aches and things because they're anxious.
Can you say that one more time?
Yes, so some cultures are maybe more somatic in the way that they display their anxiety, meaning that they're going to have headaches and body aches and stomach aches and stuff like that, versus cognitive symptoms where it's more their thinking.
Thank you.
You're welcome. We went over kind of the clinical picture. This is another opportunity. If you have any questions about it, these are what are on your advanced organizer. So are there any questions about these? I see some head shaking. No. No? Okay. Thank you. So nursing process, oftentimes when we see patients just primarily with anxiety, we see them in more of a community setting or maybe even an ER type setting. So one of the first things we have to do is determine if anxiety is the primary issue or if it's a secondary issue. So we look to see, is there an actual, medical condition? And you'd be surprised if you've never worked with patients who are having a panic attack, how a panic attack and an acute cardiac event can mimic each other. And patients can feel very similarly and they'll explain it in similar type fashions. So it's important that those patients, they get a workup to at least rule out, usually it's at least an EKG or something just to say that there isn't any, cardiac issues. But you can have anxiety secondary to a myocardial infarction or a pulmonary embolism. So we always look to see, is the anxiety primary, meaning it's an actual anxiety disorder, or is it secondary, meaning that there's a medical condition, or sometimes a substance abuse issue can cause anxiety as well. Somebody's intoxicated. Of course, other things that we assess, we look at like suicidal ideation. Sometimes when people are very anxious, they can have thoughts like that. If you remember going back to somebody who's in a panic level of anxiety, we look at their ego defense mechanisms. So remember that defense mechanisms are used to try to decrease stress and anxiety. And so a lot of times patients will utilize those, and they're not always the most mature of the defense mechanisms. And then we look at a trigger. So I think I've mentioned this before, but I always like to try to ensure that when we're talking about things like substance abuse or anxiety or even depressive thoughts, that we don't ask people what makes you anxious. We ask people what is triggering your anxiety, because we want that locus of control that owns. We want them to feel like they own how they react. And so if I say something triggers me, then I have a choice on how I react to that trigger versus if I say something makes me feel. Okay. So the diagnoses, anxiety, that one would make sense. Ineffective coping, fear. And then there's other ones. I have ineffective role performance or impaired social interaction. But fear, anxiety, ineffective coping are going to be very common ones. Outcomes and planning. Again, as always, the outcomes are more favorable the more that you can include the family and or patient as need, or you can include the patient and or family as needed. Keep in mind, though, that if I'm planning I'm more going to include somebody who's in a mild to moderate leveling of anxiety than I can if somebody's in severe to panic. I may need to make some directives, some decisions initially, and then include them as I can. Something when you're working with clients that have very severe anxiety, another thing that you always want to keep in mind is that it can be extremely draining. So you do want to make sure that you're caring for yourself, or I'm sure you've heard the term of keeping your bucket full, that we can't keep giving from a bucket that doesn't have anything in it. So you want to make sure that you're not running into compassion fatigue or burnout. So when we look at implementation then, communication guidelines, we want to make sure we're working on reducing anxiety, helping with coping and communication skills. A lot of times people are having difficulty getting their needs met. And so if we can help them have more assertive types of communication, then that can help them ensure that they're getting their needs met. And then we also make sure that we intervene in crisis. When we look at health, teaching, and promotion, we want to make sure that we're educating the patient on this disorder, on any treatments that they're going to go through, that we're looking at any co-occurring issues. So again, often we see patients with anxiety because they also have depression or suicidal thoughts, things like that. So we want to make sure we're working on those things as well. We help them with relaxation techniques, medications, CBT, cognitive behavioral therapy, works well for these patients. Promotion of sleep. So all the things that you've learned about helping somebody with sleep, it's very important when somebody is anxious. And then the last thing that I have listed is journaling. So journaling can be something where the patient can really start to look at and see what triggers their anxiety on a regular basis, and if there are ways that they can prevent that or use better coping skills with it. But journaling is really an awesome way to help a lot of patients. People use journaling in different fashions. So sometimes patients use it, as I said, to see what triggers behaviors or triggers thought patterns. And other times people use it as a way to vent. And then if they use it to vent, sometimes they rip it up when they're done. They don't necessarily go back to it. If you're trying to investigate triggers to something, then you would go back to it to see what was in it. Okay, milieu therapy. So here with our patients with anxiety, we want to make sure we have a structured daily routine and daily activities, that we have those scheduled therapeutic interactions as well as the ones that just kind of take place because you're communicating with the client. And we want to include the client in decision making as much as possible because that helps them, again, feel like they're more in control of their care, which generally helps to reduce anxiety. Psychotherapy, so cognitive behavioral therapy looks at restructuring thinking, and examining assumptions. So remember that from some of the cognitive theory we've talked about, is that we want them to restructure, examine assumptions, redefine. So sometimes people are looking at things and they're overgeneralizing, or they just have unrealistic expectations, stuff like that. And so if we can help people to learn how to restructure and be more reality-based and really make their thinking more realistic about what's going on, then that can help a lot. We also can help our patients have a little bit more positive outlook. Again, not unrealistic, but a more positive, realistic outlook can actually, so what we're trying to do here is actually cause a chemical change in their brain. So that restructuring thinking, reframing their thinking actually causes the neurotransmitters to work differently in the brain. Okay. So panic attacks, when we talk about some of these, the ways in which, the patterns in which people are thinking. So this is some of the thinking behind a panic attack is a catastrophic misinterpretation of bodily and mental disturbances. So bodily and mental disturbances. And so I can tell you, as somebody who's had probably mild to moderate panic attacks before, that your heart, people get concerned that they're going to have a heart attack or whatever, and I could see that. Fortunately, I knew what was happening when I've had them, but your heart races and you feel like you're having palpitations and you start sweating and you just feel like you can't accomplish anything in that moment besides trying to breathe, okay? So I could see how someone could misinterpret what's happening to their body and feel like there's something major going on and that they're having a heart attack or that they're going to die, something like that. And what that does is in that thought process, that worry process, that anxiety, it keeps going and it keeps feeding it. And so the panic attack lasts longer and gets more severe. Instead, if we can help people understand that when they start to have a panic attack, if they do some deep breathing, if they can calm down, if they can realize that it's a panic attack that's happening, then that can sometimes keep it from going to those more severe levels. Phobias. So when somebody has a phobia, they feel that there's danger in a specific avoidable situation, a specific avoidable situation. And we talked about those a little bit. So basically we try to help patients so that they're not avoiding those, unnecessarily avoiding those situations. Obsessive compulsive disorder is repeated warnings or doubting about safety and repetitive acts to ward off threats. So the doubting the safety or feeling like they're getting warned, that type of thing is the cognitive, the obsessive piece. And then the repetitive acts to ward off the threats, that's the compulsion piece. And so sometimes those two are linked very clearly and sometimes they're not. So you could see that an obsession about getting sick, right, which is how we all feel right now, right? So an obsession about getting sick would be washing your hands. You can see the direct link, right? You can see, I don't want to get sick, I'm going to wash my hands. So somebody will obsessively wash their hands to the point where they're raw sometimes. So it's not always that clear cut. So sometimes it's, I'm afraid my husband's going to get into an accident, so I have to turn the light switches on and off 10 times. Okay, there's no direct connection there, but for whatever reason, that compulsion allows my anxiety to go down. So the obsessions take the anxiety up, and then the compulsions, those acts, help to reduce the anxiety. And that's important to understand kind of that relationship between those two, because I'm going to get just a little bit into the treatment here. Because what we try to do in treatment for somebody with OCD is something called response prevention, but it's a little bit of a misnomer, okay? So in response prevention, what we're trying to do is to actually let somebody complete their rituals, complete their compulsions, but we're trying to gradually decrease the amount of time that they're spending on it. So if I have somebody who is extremely, obsessed with washing their hands to the point where they're raw, I still need to let them wash their hands, but maybe instead of washing them, 10 times, maybe today we can try 8. Does that make sense? And then a few days, the next day, if we do okay with that, the next day we can try 7 or something along those lines. But what we're trying to do is if you've ever seen a patient that who truly has obsessive compulsive disorder, and it causes their lives to just be completely centered around these compulsions. And so they will spend inordinate amounts of time where they can no longer function. They can't go to work. They can't take care of themselves on these rituals. So if we can cut that time down so that they can function, then that's a goal. And then anxiety disorders in general are feel of a fear of physical or psychological threat, in which there isn't necessarily one. So when we look at pharmacological, biological, integrative therapies, so these are chronic and incurable diseases. So people learn how to manage them, but they don't necessarily go away completely. So some things that we do to help is we do modeling. So we want our patients to mimic appropriate behaviors and situations. So we role model those behaviors. Systematic desensitization is another treatment, and that's a gradual exposure to decrease the anxiety response. As I mentioned, there's the response prevention, which is preventing the compulsion. And gradually helping the patient to limit the time on the ritual until the urge to do that compulsion dissipates or decreases. So it's preventing the compulsion by gradually helping the patient to limit the time on the ritual until the urge to complete that ritual dissipates or decreases. And then thought stopping, and again, I believe we talked about this one before, but this is where somebody can have like a rubber band or a hair tie or something around their wrist, and when they start to have those thoughts, the anxiety thoughts, the excessive worry, whatever it may be, they can either snap that rubber band to try to help bring them back to reality, or they can envision like a stop sign. And that's what we talked about with even depressive or suicidal thoughts, stuff like that, any sort of thought stopping. Okay, so medications. We'll go through these medications. We'll take a short pause on the recording, and then we'll move on to the other sections, okay? So antidepressants help with anxiety and depression, both. One key thing to note, though, is that antidepressants can actually initiate or enhance anxiety initially. And so if you have a patient who's getting, like an SSRI for anxiety, they need to know that it could get a little bit worse before it gets better. Okay, but we want to try to hang in there. And if it doesn't start working within a week or two, if the anxiety is too bad, then they may need a different medication. But generally, we use SSRIs, SNRIs, low dose. So usually low dose. And first-line therapy for most disorders. So SSRIs, SNRIs are first-line therapy for most. They have a faster onset than the TCAs. So TCAs are usually second or third-line therapy. However, one TCA, which is clomipramine, CLOMIPRAMINE, is a first-line therapy for obsessive compulsive disorder. It's really first-line therapy for anything with a lot of rigidity, obsession, or perfectionistic behaviors, okay? So it's important to understand because this medication comes up again. And Actually comes up a couple times. So rigidity, obsessive, perfectionistic type behaviors. And then of course, MAOIs are last line. So just, I want you to make sure that you understand that your antidepressants are gonna help anxiety on a day-to-day basis. They're gonna help prevent panic attacks, okay? But they're not gonna treat a panic attack that is actively happening. So I can't start having a panic attack and pop my Effexor, which is an SNRI, or, you know, it's not gonna treat it acutely. It's more of a prevention data. What does work acutely are benzodiazepines. So when we get into our anxiolytics, we really have benzodiazepines, and then we have a non-benzodiazepine, which is buspirone. So benzodiazepines should be short line treatment only. Shouldn't be used in patients with a history of substance abuse. So it shouldn't be used for anxiety. For patients with a history of substance abuse. Sorry, there's somebody at my house. Shouldn't be used for dependence. I'm gonna pause this real quick and we'll come right back, okay? Okay, so we were talking about benzodiazepines, so short-term treatment not used in substance abuse patients for anxiety. Remember that these can cause dependence, intolerance, and addiction. And in contrast with the antidepressants, these only work acutely. So they're not going to prevent an anxiety attack, but they'll treat one once it happens. They do tend to cause sedation, ataxia, a decrease in cognitive functioning. Generally don't like to use them in pregnancy at all. And the patient can have withdrawal symptoms after 3 to 4 months of daily use. And remember that benzos are one of the medications that can be deadly in withdrawal. Okay. Buspirone or Buspar. Oh, and then you want to make sure you know some examples, I'm sorry, of benzodiazepines. So lorazepam, we talked about chlordiazepoxide before. Those are two that are very common, so it's Ativan and Librium. Valium. There's Xanax. What's the generic for Xanax? I'm blinking. Somebody knows, you can chime in, otherwise I'm looking.
Starts with an A. And like A-M-E-P.
Is it Lazapram?
Is it alprazolam?
Diazepam. Those are the ones we see the most often. So they're on page 148 in your textbook. So alprazolam, diazepam, lorazepam, chlordiazepoxide. Okay. So I just want you to know some of those examples. Buspirone is really a class all by itself. It's a non-benzo, the only one like that. It does actually work best in patients who are benzo naive, meaning that they have not really used benzo as much. The kicker with buspirone, though, is that it takes 3 or more weeks for full effects. So it's not usually used as a PRN medication. It's one that somebody needs to be on daily, sometimes a couple times a day. But what is good about it is that it's not a CNS depressant. So it doesn't cause the sedation. It doesn't tend to have the abuse profile that benzos do. Education with somebody who has anxiety or is taking medication for anxiety, they generally should avoid excessive caffeine and alcohol. Take their medications with meals. And then especially for benzodiazepines, they need to taper. When they're coming off of benzos, if somebody's been on them regularly, it can increase seizure likelihood. Then there's a couple other medications that help as well. So one of the antihistamines, hydroxyzine. So that's HYDROXYZINE. And we actually see that used a lot. It doesn't have, it's an antihistamine, so it can make somebody drowsy and stuff, but it doesn't have the addiction issues as much with it.
Can you spell that again, Nicole?
Yep. HYDROXYZINE. Anticonvulsants, gabapentin is one that can help. And then minipress or prazosin is specific to helping with nightmares or flashbacks. Then there's a little space under there. You can put that beta blockers can help with the symptoms of anxiety. So sometimes they could be used for like a social anxiety, or if somebody has issues getting up and giving a speech, they have severe anxiety, then they might be given a beta blocker that they can just take before that, and so they won't have all of the physical symptoms that go along with anxiety. But beta blockers don't help with the cognitive piece at all. Okay. Overall evaluation, do they have decreased anxiety? Have they learned new behaviors? Are they taking care of themselves? Are their relationships better? Are they medication adherent? And have they resumed their previous roles? Any questions on anxiety, stress disorders, OCD? Seeing some head shake, no? Pretty good? All right, are we good at coming back at 10 after? It's about 9 minutes. Gives you a chance to grab a drink or whatever. Okay, I'm gonna pause. All right, so did you have any questions over the advanced organizer for eating disorders?
Could you go over some of the fill in the blanks that there were? I couldn't find them in the book.
Yes. So what I was looking for is just kind of a statement about their weight. Is that what you're talking about?
Yeah, that's what I was talking about.
Okay, so for anorexia nervosa, their weight is usually below normal. For bulimia nervosa, the weight is usually around normal, so close to normal. And then for binge eating disorder, it's usually above.
For the binge and purge, does that fall under the anorexia one? Where like you got the skinny girls that eat and then they go throw up?
Okay, so binging, you usually see in binge disorder or in bulimia.
Okay.
Purging, we usually see in anorexia or in bulimia. So when you look at binge disorder, they call it no compensatory behaviors, meaning they're not compensating for the extra calories that they're taking in, which is why they end up overweight. In anorexia, they're usually either restrictive, meaning not really taking in or doing excessive exercising, or they're purging what they do take in, not necessarily binging though, but purging with like the normal or even smaller amounts. They purge or vomiting or diuretics or enemas. And then in bulimia, you'll see the cyclic behavior where it's purging, so overeating, and it's significant. The binging is significant, and then the purging behavior to compensate for it. Does that make sense?
Yeah.
Okay. So there's a common misconception that you only see purging with bulimia, but you don't. You see it in anorexia too, depending on which subtype of anorexia that the patient has. Okay, so what I do want you to look at in the textbook is there's some tables, and I'm not going to read all of the tables to you, nor am I going to make you copy all of them, all the tables out. But it is really important when you're looking at the different disorders that you're looking on page 184 and 185, and there'll be another page that we'll look at here shortly as well. But these, the possible signs are in there. So some of the symptoms that you should see or that should be on your advanced organizer. So under assessment for anorexia nervosa, things like terror of gaining weight, lanugo, those are terms that you probably got from the reading, cachectic, low vital signs, and then the things that are in, other things that are in that table, that preoccupation of food, peculiar handling of food, rigorous exercise, the diuretics, the laxative, those things that we talked about. And please note the last bullet point under anorexia: controls what he or she eats to feel powerful to overcome feelings of helplessness. And what we're going to discuss is how eating disorders in general have an underlying issue with control. So it's really important to see how control or lack of control and trying to regain control, how control is a huge theme. With anorexia, then if you move on to page 185, you can see some of the medical complications. So when anorexia is extremely deadly. Patients will just become cachectic, emaciated. It can cause permanent damage to the heart, as well as other issues. But I do want you to have a little bit of an idea of what some of those major changes are. And then the same with bulimia. So we look there under bulimia, you should have things, it's usually a little bit later onset than anorexia. Anorexia usually happens younger than bulimia. And with bulimia, you see the binge and then often the purging through vomiting or laxatives or diuretics. See a lot of depression with bulimia, anxiety, compulsivity. And then again, the very last one, controls, undoes weight after binging, which is motivated by feelings of emptiness. So again, it's that major control feature. And then if you look at, so sorry, I wasn't recording there, so I apologize. So we're going to talk about the psychodynamic and the family influences. So psychodynamic is really a lack of control over one's body. Low self-esteem and self-doubt about a person's worth. So again, they're feeling that lack of control over themselves. So what can they control? What they put in their body, the food that they intake, and if they want to have compensatory behaviors, they feel like those can be controlled. So what happens, another thought in psychodynamic is that it results in disruption of development of age-appropriate sexual role. So really this is, you see this more commonly in anorexia, that if somebody is very cachectic or emaciated, then a female often either ceases or doesn't develop menses. So they can actually put off that age-appropriate sexual role. So that, it can be part of it, but that's not clinically, that's not what I've seen. Now, I've not worked in eating disorder clinics where they specialize in eating disorders, but I have worked with many patients who are on a psychiatric unit for other reasons and have an eating disorder. And usually I see control, self-doubt, self-esteem as the most important underlying issues. So that was control, self-doubt, and self-esteem. Also, family influences, so again, may not be a primary cause, but definitely tends to be influential. And so you see these control issues in the family. So perfectionism is often something that is important in the family, and the child has to satisfy these standards. So eating may be a lack of, or not eating, right? Eating or not eating may be a way of establishing control back, that they have one thing that they can control. You often see symptoms of eating disorders as being triggered by a stressor that the adolescent sees as a loss of control in some aspect of their life. And then when we look at genetics, you do tend to see them cluster. So eating disorders will cluster in families. Okay, so there is definitely a genetic component to it as well. So what I would like you to do, if you look at the back of this page, I think on yours, yes. So page 104. If you could please take a minute, and I'm going to pause the recording again. I just need to remember to actually start it back up. If you could we'll take about 5 minutes, and I just want you to work on your case study there. You're welcome to work with peers, ask questions of me. I'm just not going to record all that until we go through the answers. Okay. So what are some appropriate nursing interventions for Jody?
For safety.
So some things that have to do with safety. So what do you mean by that?
So like if she's having any depression, suicidal ideations.
Okay, so we definitely want to assess that to see if there's anything else going on there. And what we have to do with our eating disorders is acknowledge the fact that what we are asking, and I have this in the notes later, okay, but that what we are asking the patient to do is what they fear the most. So they're going to need some support in this. We're asking them to gain weight, okay? And particularly for somebody with anorexia nervosa, that's a goal, is for them to have some weight gain. And that's what they fear more than anything in the world. So we need to acknowledge the fact that this is emotionally difficult for the patient and support them throughout this whole process. What are you most concerned about? What are you going to do to help ensure that this patient is not safe just from suicidal thoughts, but what are we worried about here?
Monitor vital signs and electrolyte levels.
Absolutely. So we need to monitor the patient's physiologic integrity, right? So what else would be included? Vital signs? Lab
Good.
values.
Yep.
Meals.
Feel they're eating.
Eating. So the patient might need to be on even a caloric intake. Definitely would have a dietitian in it.
Weigh the patient only in a like bra and underwear.
Yep. So bra and underwear, and where do they face?
Away from the scale.
Away from the scale. So usually it's the psychologist or the psychiatrist that would divulge weight with the patient on a fairly regular, maybe once a week or something, but we do daily weights. And then I don't think we said intake and output. And this patient likely needs an EKG. Okay. We know the cardiac issues that go along with anorexia nervosa. What do we need to do education-wise? What's a piece of education this patient needs?
About their weight. Like what's an appropriate weight for them.
So they need to know what an appropriate BMI would be. And do they need to know what physical effects that having such a low BMI can do to them? Or purging or using laxatives or diuretics? I mean, they need to have an understanding of the ill effects of those things. How are we going to help because one of the goals that we have for any patient with an eating disorder is that we want to normalize eating for them. And what do most of us do? Maybe not right now, but what do most of us do when we eat?
Sit together like a group.
Yeah, you sit together, you socialize, right? So what can the nurse do?
Sit with them.
Sit with the patient. Try to have a little bit of that social interaction while the patient eats. And that can also help decrease the purging too afterwards. So, but we're trying to introduce more normalization of eating, because if somebody has issues with binging and purging, or playing with their food or having these preoccupations with food isn't something we can get away from. So it's something that we have to try to help the patient normalize. Okay, very good. So let's take a look back at the other side. So back to the handouts, to the treatments. So the priority intervention outcome for eating disorder is, of course, as we just did, physiologic integrity, nutritional balance, and then what we didn't work on because it wasn't the most important things at that moment, but self-acceptance.
Can you repeat them one more time? I'm sorry.
Yep, nope, physiologic integrity, nutritional balance, and self-acceptance. So specifically for anorexia, we do want the patient to be 85 to 90% of their ideal BMI. For bulimia, a specific outcome that we want is increasing their coping skills and not going through that binge purge cycle. For communication, a lot of times these clients are younger and they are female and they are trying to gain some control in their life. And so something that we want to avoid in this population is taking on a parental type role. And that's a little bit different than what we might do with the average 13 or 14-year-old that's hospitalized and doesn't have a parent there with them. Sometimes we're kind of that surrogate type parent, but we want to avoid it in this case because that's often a trigger for what their it's a trigger for their eating disorder symptoms. Again, as I mentioned, remember that what they fear most is the actual goal, and we need to acknowledge that difficulty of the situation. And another thing that we need to work on is their cognitive distortions. So there are a lot of cognitive distortions that go along with eating disorders. If you could please take a look at page 187, the top box to the right. So things like overgeneralization, all or nothing thinking, catastrophizing, personalization, emotional reasoning. So these are the types of cognitive distortions. These are types of things that you might hear somebody say who has an eating disorder. And so something like an overgeneralization, I was happy when I was a size 6, I must get back to that weight. So you think about a way that you might correct that faulty thinking, that overgeneralization. Is there anything that you might say back to that patient who says that to you?
Like, what about being a size 6 made you happy?
Yeah, so what, and I wouldn't say made you, but triggers, right?
Yeah.
So was there something, or were you always happy when you were a size 6? Have you had any times where you were happy and you weren't a size 6? Right? Because they're overgeneralizing it. So usually when somebody overgeneralizes, we want to have a specific example. Okay? So, and in this case, it may be a specific example of the opposite. We're trying to disprove what they're saying, that just because they're a size 6 means they're happy. So we want to try to, examine that. Was there any questions about any of the cognitive distortions? That was just one of the more common ones, is overgeneralization. You okay with those? Okay, when we look at psychotherapy, so they usually have groups or psychodynamic psychotherapy. But the ones that we look at the most are cognitive behavioral, where we look at restructuring those perceptions. And again, because it's an underlying control issue, what we usually do is, shouldn't say we, because it doesn't usually happen in a psychiatric unit, but if the patient was undergoing a treatment at an eating disorder clinic, what they often do at those types of facilities is that they actually have the patient contract for privileges. So maybe it's a certain amount of weight that they need to gain. Maybe it's a certain percentage of their meals that they need to eat without purging, but they would include the client in this decision making because that helps increase control. And then they give the client, they talk about something that client wants to earn. So maybe it's a day pass or a 4-hour leave of absence from the clinic to go someplace that they want to go with their family, whatever it may be. And so they would contract for that. So if I gain a pound by Sunday, or if I eat 50% of my meals throughout the week, and then Sunday I can earn that pass. Okay. So what that does is it puts the onus of control back to the patient or to the client. And then family therapy can help with resolving dysfunction and support the family and increase communication among the family members. So it is very often when you see somebody who has an eating disorder, there's often a lot of dysfunction in that family, in those family dynamics. So it usually isn't just the client themselves that needs help, but sometimes that whole family needs some assistance. So medications, so pharmacology, there's just a few specific ones. So fluoxetine or Prozac, that's Fluoxetine, can help with bulimia. And then olanzapine or Zyprexa, so Olanzapine, which is Zyprexa, or that clomipramine, that TCA that we talked about before can help with anorexia. Do you see how that clomiprimine that helps with that rigidity, kind of obsessive type of perfectionistic behaviors, how that should work well in somebody with anorexia? Does that make sense? Okay. And then also you got to treat the comorbidity. So a lot of times these patients have depression and anxiety issues, stuff like that. So they need to have those treated as well. Our evaluation is ongoing, and we look at short and long-term goals. Sometimes you really have to have those short-term goals so that the patient can feel like they're making progress. And prevention. So what do we do so that we have less eating disorders in the population in general? Is we need to talk to children because these can happen as early as 12. I mean, there's cases of it happening even earlier than that. But if we can talk to kids and help them learn how to communicate, so learn how to recognize and express their feelings, learn how to recognize and express their feelings. Although if my daughter's any indication of that, you can go overboard with that one too. Conflict resolution, how to express when needs are not met. How to express when needs are not met. And so really what we're doing is teaching assertiveness, right? If we're talking about conflict resolution, it's really assertiveness as well as communication. And then coping, what do you do when you cannot directly solve a problem? So, we teach people to problem solve, right? But there are times when there are issues, like right now, there's issues that you can't fix. You can't change it. So we need to teach our children how to cope with stressors, and that can help to decrease the likelihood that they'll develop eating disorders. Hey, are there any questions? I'm going to go ahead and stop recording.